Margaret was 71 years old and she came into my office on an ordinary Thursday afternoon carrying a plastic grocery bag. Inside that bag were 11 pill bottles, some prescribed by her cardiologist, some by her rheumatologist, a couple by her primary care doctor, a few she'd bought herself off the shelf at the pharmacy, and a handful of supplements her neighbor had recommended. She set the bag on my desk, looked at me, and said something I have never forgotten. She said, "Doctor, I take all of these because I'm trying to stay healthy. But I honestly have no idea what half of them do, or whether they're supposed to be taken together. I have been a cardiologist for a long time now. My name is Dr. Mike, and in all my years of practice, that sentence from Margaret captured something I see almost every single day. Not villainy, not a conspiracy, not doctors trying to harm their patients, something quieter, and in some ways more common than any of those things. A situation where an older adult is taking a growing pile of medications prescribed piece by different people over many years, and no single person has ever sat down and looked at the whole picture at once. I want to talk to you today about that picture. Because if you are over 60, or you love someone who is, this is information that could genuinely protect a life. Not by scaring you away from medicine, not by telling you your doctor is your enemy, but by helping you understand how medications behave in an older body, where the real risks hide, and what you can do to stay safe. This is not a warning to throw away your prescriptions, it is an invitation to understand them. Let me start with something true that most people are never told plainly. Your body at 70 does not process medication the same way it did at 40. This is not a scare tactic, it is basic physiology, and every good doctor knows it. As we age, our liver metabolizes many drugs more slowly. Our kidneys, which clear a great deal of medication out of the body, filter less efficiently than they once did. We tend to carry a little less water in our tissues and a little more body fat, which changes how certain drugs distribute and linger. And our hearts, our blood vessels, and our nervous systems simply have less reserve to absorb a shock. What all of this means in practical terms is that a dose that was perfectly reasonable for a 50-year-old can be too much for that same person at 75. It means a medication that caused no trouble for years can start causing trouble as the body changes around it. And it means that combinations of drugs that would barely register in a younger person can interact in ways that matter a great deal in an older one. This is precisely why geriatric medicine exists as its own field, and why doctors who specialize in older patients spend so much of their time not adding medications, but carefully reviewing and sometimes removing them. There is even a formal name for the practice of thoughtfully reducing unnecessary medications. It is called deprescribing. It is a real evidence-based part of good medical care, and I mention it now, near the very start, because I want you to understand the spirit of everything I am about to say. The goal is never to trick anyone into abandoning treatment they need. The goal is to make sure that every pill a person takes is actually earning its place. Now let me tell you about the 5 areas where I see the most avoidable harm in older patients. I am not going to tell you these medications are poisons. Many of them save lives every day, including the lives of people I care for. What I am going to tell you is where the danger genuinely lives, so that you can recognize it and talk about it intelligently with your own doctor. The first area is a mistake that has nothing to do with any single drug and everything to do with all of them together. Doctors have a word for taking many medications at once. The word is polypharmacy. It usually gets defined as taking 5 or more regular medications, and by that definition, an enormous number of older adults qualify. Polypharmacy is not automatically bad. Some people genuinely need many medications, and stopping them would be dangerous, but polypharmacy raises the odds of 2 things that quietly cause harm. The first is drug interactions, where one medication changes how another behaves in the body. The second is what we call a prescribing cascade, where the side effect of one drug gets mistaken for a new illness, and a second drug gets added to treat it, and then that drug causes its own side effect, and so on, until a person is taking a stack of pills where several of them exist only to manage problems created by the others. I want you to sit with that idea, because it is far more common than any dramatic story of sudden collapse. A blood pressure medication causes ankle swelling. Instead of questioning the blood pressure medication, a water pill gets added. The water pill lowers potassium, so a potassium supplement gets added. The potassium interacts with a different heart medication, and on it goes. No one did anything malicious at any step. Each individual decision looked reasonable, but the whole assembly, viewed together, became a tangle that no one had ever untangled. This is the single most important thing I can teach you today, and I am placing it first on purpose. The greatest risk for most older patients is not one dangerous pill, it is the absence of anyone looking at the entire list at once. The second area involves a category of medicine that most people do not even think of as risky, precisely because they can buy it without a prescription. I am talking about the common over-the-counter pain relievers known as NSAIDs. These include ibuprofen and naproxen, the familiar tablets that millions of people reach for when a knee aches or a back stiffens or a headache sets in. In moderation, for a younger person, these are generally reasonable. But in older adults, especially those with heart conditions, kidney issues, or high blood pressure, regular use of these drugs deserves genuine caution. Here is the honest picture, without exaggeration. NSAIDs can cause the body to retain sodium and fluid, which can nudge blood pressure upward and can strain a heart that is already working hard. They can reduce blood flow to kidneys that are already less efficient with age, and they carry a real risk of irritating and bleeding the stomach lining, a risk that grows in older people and grows further when someone is also taking a blood thinner. Major medical organizations advise real caution with regular NSAID use in older adults with cardiovascular or kidney disease, and that advice is grounded in solid evidence. This does not mean an occasional tablet for a genuine ache is a catastrophe. It means that quietly taking these pills every single day for months, without anyone knowing, is a habit worth bringing into the light and discussing. If you rely on them daily, that is a conversation to have, not a reason to panic, and there are often gentler ways to manage chronic pain that your doctor can help you find. The third area is a group of medications called proton pump inhibitors, the acid-reducing drugs many people take for heartburn and reflux. Common ones include omeprazole and pantoprazole. For someone with a genuine ulcer, severe reflux, or a real need to protect the stomach, these can be exactly the right medicine, and for those people they can prevent serious complications. But here is where the caution comes in. These drugs were designed for defined courses of treatment, and yet a great many people end up taking them for years and years, often long after the original reason has faded, simply because no one ever revisited the decision. Long-term use has been associated in studies with lower levels of certain nutrients the body absorbs with the help of stomach acid, including magnesium and vitamin B12, and with a modestly increased risk of certain infections and bone fractures. I want to be careful and truthful here. Association is not the same as proof of direct cause, and for people who truly need these drugs, the benefit clearly outweighs these modest risks. The real lesson is not that these medications are secret killers. The real lesson is that they are a perfect example of a drug that should be reviewed periodically, rather than simply refilled forever on autopilot. If you have been on one for years, a fair question to ask your doctor is simply, do I still need this, and if so, are we monitoring the things worth monitoring? The fourth area concerns blood pressure medications, and I want to approach this one with special care, because this is exactly the sort of topic where bad information causes real deaths. Controlling high blood pressure is one of the most important things we can do to prevent strokes and heart attacks. Nobody should ever stop a blood pressure medication on their own based on something they read or watched. What I want to talk about instead is a subtler risk that is well recognized in geriatric care, and that is the risk of blood pressure being lowered too aggressively in a frail older person. In an older body, the systems that keep blood pressure steady when you stand up can become sluggish. When blood pressure drops too far, especially on standing, a person can feel dizzy or lightheaded, and this leads to falls, and falls in older adults are not minor events. A broken hip or a head injury from a fall can be life-altering or even fatal, and falls are one of the leading causes of serious injury in people over 65. So the goal in older patients is often a thoughtful balance, tight enough control to protect the heart and brain, but gentle enough not to cause the dizziness and falls that come from overshooting. This is a conversation about the right target for you, at your age, with your particular health, and it is a conversation your doctor should welcome. The action item here is not to stop anything. It is to report dizziness, lightheadedness on standing, and any falls or near falls, because those symptoms are meaningful clues that a dose may need adjusting. The fifth area is closely related, and it is the risk of certain heart and blood pressure medications affecting the body's electrolytes, particularly potassium. Some very valuable drugs, including a class called ACE inhibitors, can cause the body to hold on to more potassium. For most people, this is well tolerated and even part of what makes these drugs protective. But in an older person whose kidneys are working less efficiently, or in someone who is also taking a potassium supplement or using a salt substitute made from potassium, levels can climb higher than intended. Potassium that rises too high can disturb the heart's rhythm, and that is a genuine reason these drugs come with recommendations for periodic blood tests. Again, notice what the real lesson is. It is not that these medications are murderers hiding in your cabinet. These are among the most beneficial drugs we have for protecting hearts and kidneys, and countless people live longer because of them. The lesson is that they deserve monitoring, that potassium supplements and potassium-based salt substitutes should never be added casually without telling your doctor, and that the safety comes from the follow-up. A drug that is checked and monitored is a drug working as intended. A drug that is prescribed and then never reviewed for years is where the quiet risk grows. So let me now bring all of this together, because the pattern underneath all 5 areas is the same, and once you see it, you cannot unsee it. In every case, the danger is rarely the medication sitting there doing exactly what it was designed to do. The danger is time, and change, and lack of review. Bodies change with age, kidney function drifts, new drugs get added by new specialists who cannot see the full list. Old drugs stay on long after their reason has passed, and somewhere in that slow accumulation, a combination or a dose that was once fine becomes a combination or a dose that is no longer fine, and nobody catches it because catching it requires someone to stop and look at everything at once. That is the story of Margaret and her plastic grocery bag. When we finally sat down and reviewed all 11 of her bottles together, we found that 3 of them were no longer necessary at all, leftovers from problems that had resolved years earlier. 2 were interacting in a way that was making her tired and unsteady, and one of the supplements her well-meaning neighbor had recommended was working against one of her prescribed medications. We did not do anything dramatic. We did not throw everything out. We carefully, slowly, and with proper monitoring, simplified her regimen down to what she actually needed. Within a couple of months, she told me she felt clearer, steadier, and more like herself than she had in years. That is what good care looks like. It is not heroic. It is just attentive. So here is what I want you to actually do with this, and none of it involves stopping a medication on your own. That first step matters so much that I will say it plainly. Do not stop any prescribed medication based on this video. Some of these drugs, if stopped abruptly, can cause exactly the kind of harm we are trying to avoid. The power here is not in quitting, it is in asking. Start by doing what Margaret did. Gather every single thing you take, every prescription, every over-the-counter tablet, every vitamin, every supplement, every herbal remedy, put them all in one bag. Then make an appointment with your doctor or pharmacist specifically for a medication review. That is a real appointment you are allowed to ask for, and a good pharmacist in particular can be extraordinarily helpful here, because reviewing medication interactions is precisely what they are trained to do. When you sit down, ask a few honest questions about each item. What is this for? Do I still need it? What are the risks for someone my age? Does it interact with anything else on my list? Is there anything we should be monitoring with a blood test? And is there a plan for how long I should stay on it? These are not rude questions. They are exactly the questions a thoughtful doctor wants their patients to ask. A good physician will not be offended. They will be relieved that you are engaged. Pay attention to your body and report what you notice, because your symptoms are valuable information. New dizziness, especially on standing, any falls or near falls, unusual fatigue or muscle aches, swelling in the ankles, a persistent cough that appeared after starting a new drug, confusion or memory changes, stomach pain or dark stools. These are the kinds of clues that let a doctor adjust something before it becomes a crisis. You are not being a difficult patient by mentioning them, you are being an excellent one. And for the everyday things, use good sense that you already understand. Do not take daily over-the-counter painkillers for months on end without telling anyone. Do not add supplements or potassium-based salt substitutes without checking whether they interact with your prescriptions. Keep an up-to-date list of everything you take and carry it with you so that any doctor you see in any office or any emergency room can see the whole picture at once. That single sheet of paper is one of the most protective things an older adult can own. I want to end by being completely clear about what I have and have not told you today, because I would rather you leave with the truth than with fear. I have not told you that medications are poisons. They are not. The medications we discussed have saved and extended millions of lives, and for a great many people, including many of my own patients, staying on them is exactly the right and life-preserving choice. I have not told you that doctors are villains. The overwhelming majority are dedicated people doing careful work in a system that makes it genuinely hard for any one of them to see a patient's whole medication list. And I have most certainly not told you to stop anything on your own. What I have told you is this: the body changes as it ages, and medications must be reviewed as the body that takes them changes. The greatest hidden risk for most older adults is not a single dangerous pill, but a whole list that no one has examined together in a long time. And the most powerful thing you can do to protect yourself or someone you love is not to fear medicine, but to engage with it, to ask questions, to request a review, to notice symptoms and speak up, to be, in the best sense of the word, an active partner in your own care. Margaret is doing well. She still takes the medications she genuinely needs, and she takes them with confidence now, because she understands what each one is for. That understanding, that partnership between a patient and the people caring for them, is the real medicine here, not fear, knowledge. If this was helpful, share it with someone over 60 whom you love, and encourage them to book a medication review. That single conversation, that one bag of bottles brought into the light, could be one of the most protective things they ever do. Take care of yourselves, ask good questions, and never stop learning about your own health. I am Dr. Mike, and I will see you next time.